Why does the Academy invest in evidence-based medicine? It clearly improves patient care, decreases variation, and patients trust physicians, and we have to synthesize a very large and growing orthopedic literature. The Academy has had a 20-plus year commitment to using evidence to drive quality. There's been a series of committees that have evolved addressing guidelines, appropriate utilization criteria, and now performance measures to improve the orthopedic care that we provide. Clinical practice guidelines, these define how to best manage a condition in a particular patient. Basically, when should a procedure be performed? Appropriate utilization criteria, you evaluate the specific indications for a procedure for a specific patient or clinical situation. Basically, it's in whom should a procedure be performed. Performance measures are tools to evaluate the quality of the outcome of the work we do based on guidelines and appropriate utilization. Cost evaluation, the clinical practice guidelines are now including the section on cost evaluation if literature exists. We're not doing any value calculation currently because the methodology for that is still evolving. But health systems, especially those investing in ACOs or alternative payment models, they are increasingly accepting risk, and they are going to do their own value analysis for orthopedic procedures because it's critical for their financial health. Orthoguidelines.org has a nice cell phone app you can download to your cell phone. It has all the guidelines. You can sort the recommendations by strength of rating, the stage of care. You can also access appropriate utilization criteria. Well, quality improvement programs have to be based on the highest quality research to contribute to these quality guidelines, appropriate utilization criteria, and performance measures. And this research and data drive the quality improvement cycle. And I'll take you through this quality improvement cycle that the Academy uses that always starts with evidence-based systematic reviews. These lead to multiple products, including safety checklists, decision-making tools, guidelines, utilization criteria, and performance measures. This leads to outcomes in patient care, future research, education, and policy review, evidence analysis, and the cycle continues with these systematic reviews to get better evidence. What's the goal of society and payers? We all want value, and that's quality divided by cost. That C part of the equation, we haven't looked at this too much as physicians and providers in the past, but increasingly we're going to be asked to make these decisions about is medication A, implant A, or procedure A more valuable than alternatives in those categories. Historically, we haven't done this, but we're going to have to do this even more in the future. Well, why is orthopedics at the center of the bullseye? Well, if you look at Medicare, 3 of the top 7 expensive conditions include osteoarthritis of the hips, knees, and shoulders, and spine, very expensive condition. For non-CMS patients under 65, trauma, shoulder, knee reconstruction, scoliosis, DDH, these are very expensive conditions. I always try to break things down into a value and cost grid, and if you look at things like immunizations, they're pretty cheap and pretty good return on that investment. Hip replacement may be one of the most valuable operations, not just in orthopedics, but in all of healthcare currently, but it is high cost, but it has very good values for society. Low cost, low value, like chondroitin sulfate, probably doesn't work, but it's pretty inexpensive. But there are expensive things like knee arthroscopy for degenerative arthritis and hyaluronic acid, neither of which have been shown to offer much improvement and a relatively high cost. If you look at the overall burden, which Dr. Swankowski alluded to earlier, the direct costs are approaching 5% of our GDP. The indirect costs are about 3%, and that comes out to almost 8%, approaching $1 trillion, the impact of musculoskeletal conditions on our academy. Because of this enormous musculoskeletal disease impact, Dr. Coker, Dr. Tung, Coker, and others spent a lot of time looking at this, and they started out with a hypothesis about 10 years ago that spending money to treat orthopedic conditions results in a net savings to society. We keep patients mobile, we reduce pain, improve function, we keep them working or get them back to work, and they maintain independence. Orthopedic surgery is an expense, but we invest this to fix the problem. But orthopedic surgery is a cost-saving investment because we reduce the other societal costs of injury and disability. If you look at the economics of knee replacement, we invest about $40,000 in a knee replacement, but there's a lifetime societal benefit beyond that of about $20,000. This has estimated that we save about $20 billion a year for society with these number of knee replacements done annually. We see similar results with ACL reconstructions. The difference is that they're a little less expensive, and we get a longer-term return on that investment. Short-term savings, about $4,500, but long-term savings approaching $50,000. That's $10 billion in savings to society annually. Orthopedic procedures are cost-effective because they save money for our society. We get a significant return on that investment, and we maintain a healthy, active workforce. But we need better messaging and research to continue support for valuable but costly orthopedic care. We'll talk about variation now. There's remarkable variation throughout the United States in terms of rates of surgery, types of surgery for the same